Please.
Okay, your time starts now. Regarding clinical stage 1 seminoma, what are all the treatment options available?
So for clinical stage 1 seminoma, the treatment options following radical orchidectomy would include surveillance or administering a single dose of carboplatin to reduce recurrence. There's also the option of retroperitoneal radiotherapy with 20 grays, but we don't routinely do that in the UK.
Okay, what about stage 1 non-seminomatous germ cell tumor?
So for stage 1 NSGCT, the options are single course of BEP, bleomycin, etoposide, and cisplatin, or surveillance or upfront RPLND, which again we don't routinely practice in the UK.
Any specific histology factor which will influence the patient's prognosis?
So the histological factors for seminomas will include tumor size more than 4 centimeters, as well as retotestis invasion. For non-seminomas, it would include lymphovascular invasion, embryonal elements more than 50%, or proliferation more than 70%.
For a patient who decides to have RPLND for stage 1 non-seminomatous tumor, what is the prognosis and what is the main outcomes?
So this is major surgery, needs to be explained to the patients. This will also be diagnostic in terms of full staging. If, for instance, this lymph nodes yield active tumor cells, in which case the patient will then require chemotherapy. With regards to the risks of complication, there is up to a 20% risk of morbidity associated with this. Risks include major bleeding from abdominal vessels, chylous peritonitis, as well as anejaculation if the sympathetic chain or hypogastric plexus is affected. So this needs to be explained carefully to the patient.
Any histology found in the testes will make you to go for primary RPLND and not to choose surveillance or any chemotherapy.
I think if a mature teratoma is seen, that will not be radio or chemosensitive, so that may be an indication for primary RPLND.
Okay. What is the treatment for stage 2A and B seminoma?
So stage 2 A and B will stage 2A?
Yeah.
I'm not exactly sure.
Okay, stage 2A, say for example, lymph nodes less than 2 centimeters. Normal markers.
Lymph node stage. Oh, I see. Okay. So lymph node stage. So N2. I'm still not very clear on the question. Sorry.
Okay. The lymph nodes less than 2 centimeters, markers were normal. Seminoma is the primary histology from the testes.
Oh, right. Okay. So in terms of the clinical staging, so for stage 2A seminoma, this will fall into the good prognosis group for the IGCCG category. So the patients will require 3 courses of BEP, or if there are contraindications to giving bleomycin, then patients can have 3 courses of cisplatin, ifosfamide, and etoposide.
Okay. So what will be your choice if it is the same stage 2 but the primary histology is non-seminomatous germ cell tumors?
So that will also fall into the good prognosis for non-cell NSGCT. So the treatment again will be 3 courses of BEP.
Okay. What is the treatment for metastatic germ cell tumor? Let us assume that initial staging itself showed pulmonary metastasis.
So in the presence of, can I just clarify, is this for seminoma or non-seminoma?
Seminoma?
Okay, so if there's a pulmonary metastasis in seminoma, in the absence of any visceral mets, this would again fall into the good prognostic group. And so the treatment option will be 3 cycles of BEP.
How will you differentiate this prognostic group? What is the criteria?
So the International Germ Cell Cancer Collaborative group has, for seminomas, has classified them into good and intermediate prognosis, and there's no bad prognosis for seminoma. And the factors taken into consideration in terms of histology or metastasis is the presence of non-pulmonary visceral mets makes the patient an intermediate prognosis for seminomas, whereas everything else falls into good prognosis. For non-seminomas, there's good, intermediate, and poor prognosis. Histologically, if the primary tumor is in the retroperitoneum or in the testis, that will be a good prognosis. If the primary tumor is in the mediastinum, but there's no visceral mets, then this is intermediate group. If there is extrapulmonary visceral mets, then this would be poor prognosis. Also, the S category comes into place as well. So S1 will be good, S2 will be intermediate, and S3 will be poor.
Okay. In clinical stage 1, yes, tumors, and the ultrasound examination of the opposite testes and repeat imaging, everything is stable, there is opposite testis normal, and the tumor markers are just slightly elevated. What is your follow-up?
So with raised tumor markers, one worries of presence of retroperitoneal or lymph node mets, and so full staging CT will need to be reassessed at MDT, and considerations would either be to give chemotherapy,
Okay.
depending on the CT findings.
Okay, what is your treatment protocol for seminoma patients with retroperitoneal residual masses more than 3 centimeters?
So for seminoma patients with retroperitoneal mass more than 3 centimeters, one is concerned that this will harbor live active tumors. So this patient will need a PET scan to look for avidity, and following on from that, a biopsy to confirm this. And then MDT will likely recommend a full course of second-line chemotherapy, which could be BEP again, or cisplatin, ifosfamide, and etoposide.
What type of PET scan you will perform?
FDG PET scan.
Okay, what is your protocol for the residual mass in non-seminoma?
So for non-seminomas, if there is a residual mass, then patient goes on to retroperitoneal lymph node dissection.
Any investigations?
So there's no role for PET scan for non-seminomas. Tumor markers can be done to assess if tumor markers are still raised. If they are raised, then patient will require further chemotherapy. If the tumor markers are stable or plateaued, then patient can go on to have RPLND.
Is there any size criteria below which you can avoid RPLND?
1 to 2 centimeters.
Okay, 1 centimeter.
1 centimeter.
Anything less than 1 centimeter you can observe. The scenario is complete now. So anything
Okay.
less than 1 centimeter you can observe. There is a 9% recurrence chances, but anything more than 1 centimeter you need to do bilateral RPLND.
Okay.
And RPLND is the primary choice compared to chemotherapy. And as you said, there is no role for FDG PET in non-seminoma.
Yeah.
Usually, at least 6 to 10% of these residual masses contain active cancer. 50% may have post-pubertal teratoma. 40% will be only like a necrotic fibrous tissue.
Yeah.
And taking you back, I'm quite happy with your international germ cell collaborative classification. You try to nail it as much clean as possible. The primary RPLND is for teratoma, and instead of saying just teratoma, you can say teratoma with somatic malignant component in the testes.
Okay.
So TSMC. So if there is
Okay.
a teratoma with somatic malignant component in the testes, we need to plan for primary RPLND since teratoma is not amenable to chemotherapy.
Okay.
Any stage 2, try to divide it into S0 and S1 because both are in stage 2, and then based upon the S0, S1 you can take it forward. And IgCCG, as you said, using the testicular tumor markers are very important, and I'm quite happy, as I said, you are divided into non-seminoma into 3 groups and seminoma into 2 groups. When you are saying that, you need to mention that in seminoma it is irrelevant what the tumor markers are. Whatever the tumor markers, it all depends upon whether there is pulmonary, non-pulmonary visceral mets present or absent. That's the main thing, differentiate between good and intermediate prognostic group. Okay?
Yep.
Good. So overall, in my view, you can divide the whole testicular cancer gambit into 3 sections. The first section is the preparation of the patient, testicular tumor markers, examination, as you said, taking the patient by the foot into the scan machine, and initial staging of CT scans and preparing for orchiectomy. And the second section is like, how will you do orchiectomy, why high inguinal orchiectomy, how are you going to secure the cord stump, what is the role for testicular prostheses, what is the role for opposite testes management in case if it is synchronous or metachronous tumor or solitary tumor. That is the second group. Third group is purely oncological. So once the histology comes, usually in our practice, as you know, the MDT will refer the patient to a tertiary testicular cancer SMDT, and usually they will take care of the retroperitoneal imaging, chemotherapy. Of course, if there is a need for RPLND, it will fall back to a urologist if the particular urologist is having a special interest in RPLND. But mostly it will end up in the hands of the retroperitoneal sarcoma surgeons who have more volume and more expertise.
Okay.
So in these 3, the part 1/3 of first and second are very important, and I'm happy you're quite strong in all 3. The third 1/3, the last fagend, is little bit very memorizing thing, and you just have to clearly, nicely plot it out, write in a clean A4 sheet. It will take like 1/4 of your sheet. What is the plan for the last 1/3 of the section? First 2 1/3 will be easy to understand. That's what we do day in and day out. Usually in the exam, your 10 minutes will be, we have done 30 minutes dividing in the 3 parts series. Usually in the exam, the first 2 parts itself easily take out your 9 minutes of your section if you're fast and the examiner really wish to push you forward without discussing TNM staging, without discussing IgCCG staging, and you end up in a very high level discussion. So the last 1 minute only you will be touching this last 1/3. you're at good stage. So if you're able to mug up and bring out the main indications for RPLND, the peculiar things like teratoma, the peculiar things like absence of FTG PET for indications in non-seminoma, if you're able to bring out those things, that's it. You're
Okay.
encashing the full testicular tumor scenarios in an absolute full mark.
Thank you.
Okay.
Thank you.
Yeah, as I
I
said,
got slightly confused when you asked about stage 2A, but I then realized that actually it's the full staging, combining the TNM to get the stage 1, 2, and 3. So it took me a bit of time to understand the question, but I later on realized what you were asking.
Yeah, because if it is like the discussion-based sessions like how we did 5 weeks back or 1 month back in the starting stage, I can give you some clues. I really want to keep my mouth shut like an examiner so that you have the real time experience for the 10 minutes, and then later I can help you with any clues and etc. So overall, the testicular cancers are very straightforward. First 2/3 of the section will go exactly same way, then it will divert based upon the histology of seminoma or non-seminoma, but by the time you'll be easily at 9 minutes. So understand the protocols for seminoma and non-seminoma, stage 1, stage 2, and bring in the IGCCC staging, and then you can sail through. Mostly you won't be able to bring out the so many things we have revised and read, but that's how it has to be. Your knowledge should be more than what you are able to express on the day. So that the examiner should feel, okay, he has spoken for the 10 minutes, but I know he knows more than what he has spoken. That confidence you should give it to the examiner. Okay, that comes with using less words and using a very swift, clean answers. I'm quite happy with your communication and application of the knowledge. That should give the examiner a confidence, okay, this guy is good. There is no point in asking TNM stage. Let's just go to the next one. If I ask IGCC staging, he's going to really take next 1.5 minutes explaining the poor, intermediate, and high risk, and then I know he knows. Let's go for the next one. That you should see that examiner's pace pushing you to the last 1/3 section. That's where the victory lies.
Okay.
Very good. Any other feedback from yourself?
No, I think this is very useful. I think we've covered the whole breadth really of testicular cancer, and the third part, which is the oncological bit, is clearly what we don't tend to do. And even in MDTs, it's the oncologists who sort of champion the discussion.
Yeah, and usually they will take it onward. Unless if you are really in the testicular cancer SMDT, you won't even hear the actual clear discussions.
Absolutely. Yeah.
Good.
But that's very useful. I think we've covered the 3 possibilities. So hopefully the exam goes well. Should be.
And as usual in the YouTube, you can see the clear slides. So when you are revising using the YouTube, try to pause and get the maximum out of the slides. We should really thank Anish, who has done all the hard work of preparing the slides. And if I cover the slides completely, it will be easily 5 or 6 scenarios, but 3 10-minute scenarios is more than enough to cover. If you guys are interested in a little bit more beefing up, I think the slides in the YouTube will really help you. You don't have to really refer to everywhere.
Yeah. Thank you so much. Thank you. That's very helpful.
Good. Have a nice rest of the day. I will catch you back in next few days' time.
All right, you too. Thanks. Bye-bye. Bye now.
Cheers. Bye.